From Flourish DX, this is the Psych Health and Safety Podcast. With workplace mental health becoming a safety prerogative, this is the source of information on psychological injury prevention and health promotion.
Hi, and welcome to the Psych Health and Safety Podcast. My name is Joelle Mitchell, and I'm one of the hosts of the show. The aim of the podcast is to rapidly introduce the knowledge and application of psychological health and safety in workplaces worldwide. To help with this, we have regular guests from around the world who are leading the way in this important area. Before I introduce our guest and topic for the day, allow me to introduce my co-host, Dr. Alicia Pappas. How are you today, Alicia?
Joelle, I'm well, thank you. I'm dialing in from Queensland this time, not my usual Melbourne. I've just come up to the Gold Coast for a few days, so you can probably notice my background's a bit different, but it's nice and sunny here, so a nice change from freezing Melbourne.
Very nice. Nice to have a little, so you're having a bit of a staycation there, aren't you? You're house sitting for friends?
I am, yes. So they've gone away today for a few days. So they've got a little dog who's a bit elderly and needs his medication. So I said I'd come up and dog sit and house sit. So it's the benefits of working with the team. We can be pretty much based anywhere now. So, yeah.
That's it. Remote working certainly has its perks, doesn't it, Alicia?
Mm-hmm. It sure does.
What has your life become? Well, my life has become being able to travel to the Gold Coast for a week and still work.
Yes.
What an awful life this
Terrible,
is, working remotely. All right, well, let's introduce our guest for today. She is a WHS professional with 15 years of service in the Australian Capital Territory public healthcare sector, offering leadership and expertise in work health and safety and clinical safety. She is the Director for Occupational Violence Prevention and Management and WHS Projects at Canberra Health Services. Welcome to the podcast, Peta Merceica.
Thanks, Joelle and Alicia. And I just want to acknowledge that I'm coming from Ngunnawal and Ngambri land, so Canberra, which is also freezing like Melbourne, maybe next level freezing, but nice today.
Wonderful. And thank you so much for joining us today. We'll be talking about this topic of occupational violence in healthcare, and it's a topic that we haven't really addressed before on the podcast, so I'm really keen to hear what you've been working on.
Yeah, so Peta, before we jump into occupational violence specifically, we like to ask all our guests if they have any favourite podcasts that they're listening to, whether that's related specifically to workplace mental health or more broadly. Anything you've got playing at the moment?
Yeah, so I am a big fan of podcasts, so I had to kind of edit my long list. So I went onto the app and was scrolling, and I'm like, okay, I need to rein it in. But I normally look at work-related ones like your psych health and safety and the safety of work, those type music-related ones. So Song Exploder is one that I've been getting into, and the J-Files. But the one I kind of wanted to highlight was one I found recently, and that's Black Magic Woman by I wrote her name down, so I want to get it. Mundanara Bales, and I found that by accident recently. My favourite author, Anita Heiss, was a guest on her podcast, so now I'm busy catching up with old episodes. There's like a lot to catch up on, so that's my favourite at the moment. But yeah, I listen to them a lot when walking and driving. So
they're always good to catch up on. You do your more automatic activities, and you can just have it on in the background and catch up on topics of interest or professional interests. Yeah, amazing. So that one that you've just mentioned, what's the theme of it?
So the one that I listen to, she does like a book club once a month, so talks to an author, and then she does other ones. So famous actresses, like recently was Peta Merceica. I don't know if it was recently, but it was one that I caught up on. So speaking with awesome Indigenous women from Australia. So that
amazing.
Yeah, it's really good. It's a good accidental discovery.
As we're moving more into talking about occupational violence, just before we go into that topic specifically, can you tell us about your professional career today?
Okay, so when I finished school, I didn't really know what I wanted to do, but something that was supporting or helping people was the goal. And so I did psychology at uni, and I really wish I knew about all psychology then, because the thought of doing sort of a clinical type role didn't appeal to me. But anyway, I'm kind of working in that space now, just about 20-something years later. And so I did some random jobs, travelled, and I think I got interested in safety in about, I think it's 2001 when I started a role in a lift company. So I had this job where I was a logistics officer, which meant buying elevators from Finland and Italy. So I got to spend lots of money in those countries, but I was buying, big metal boxes to put in buildings, pretty much. And became the health and safety rep in that role for the building. So we had a warehouse and office, mostly risks, but that sort of started my interest. And then I got offered a job in Canberra, and I think a lot of people thought I was crazy at the time, but I just really wanted a change of scenery. I've always lived in Sydney most of my life, so jumped at the chance, but cheekily asked if I could do safety as well. And it was convenient because the guy who was already doing safety was about to retire. So they're like, sure, you can do that, because no one wants to do safety except safety nerds like myself. And so when I moved to Canberra, they paid for me to do a Cert 4, and I really liked the approach of the new safety manager. He was like, get out into the field as much as you can. And the other thing that we did at that time was implement a new safety management system. So for a new safety person, it was like ideal. You learn the Australian standard at the time was 4801. Now we've gone to the ISO standard, but I pretty much learned that by implementing a safety management system with the guidance of this safety manager. He was based in Sydney. And he also, as a new person going into a male-dominated field, I felt really kind of, nervous and maybe not as confident as I should be. And he was like, I don't care if you make a mistake. I always have your back. I will support any decision that you make. And so that made me feel a bit more confident when going on to construction sites and things like that. And the hands-on bit, I remember going onto site with one of the installation guys, Steve, and he asked me to come on site just to see the installation process. So we're sitting in the bottom of a lift pit, and he's showing me how we put the machinery in. And it was the middle of winter in Canberra. Even the puddles were frozen. So I think it gives you a bit of street cred, but it also is really eye-opening. And I can't get that hands-on because I'm not an engineer, but I can pass tools. So that's kind of how I was helping. But it was, I think it's really good to be a bit more, to be out there and not an office-based safety person, if that makes sense. So after that role, I did the Canberra thing and got a public service job, and that's with the health service. And so that was late 2007. So that's about 15 years. And in the middle, I did a quality and safety role with mental health. And that gave me a bit more information about how a health service works, what the patient safety issues are. So not just mental health, there's obviously suicide and self-harm, and then the violence risk, but there's also medication safety, falls, pressure injuries. So, it's quite extraordinary how broad it is in a health service. So that's why I think I like that. I like that kind of role because no 2 days are the same. That's a very cliche thing to say, but the broad range of safety hazards plus the patient safety stuff on top of that is just phenomenal what staff manage on a day-to-day basis. My role started in 2018, this occupational violence role. I finished my master's in workplace safety and went back to the work health and safety role. So it was quite good timing.
Amazing. So you've been there for quite a while, and your role has evolved since you've been there. And yeah, you're right. It's depending on what organisational context you work in, there'll be different hazards presenting themselves, and the space you work in. Obviously, there's a broad range.
Yeah.
Yeah.
So let's talk a bit more then about your current role. So Director, Occupational Violence Prevention and Management at Canberra Health Services. Can you tell us what that role involves? Sure.
So 2018, I went back to work health and safety and started just to I let my manager know at the time that I was interested in this issue. And so I did some work as a senior safety advisor with the data collection and getting the back of house right in our work health and safety team. And the role commenced in late 2018. And it involves a strategic piece, which is the occupational violence strategy, policy and procedure type work, and then the operational stuff that a normal work health and safety person would do, risk assessments, incident investigations, and support for managers and staff, and then the normal government business such as briefs, questions on notice, that kind of stuff. And then I guess it's probably a newish term that I've heard, but internal consultancy type role as well, which I really enjoy. It's more working with a team that has a complex issue with occupational violence and coming up with strategies or brainstorming or but working as a team to help resolve the issue. And I've got to be mindful about confidentiality and sharing examples. So I'll just do generic type ones, but I've been working with teams before where I've done a presentation about what sort of procedures we can implement for this team. And then at the end, we'll do a bit of a brainstorm about a particular case. And it might be a patient that has complex comorbidities, and sometimes they display behaviours of concern and then we sort of work towards having a strategy or a few strategies in place to make sure that staff are safe and that the patient is receiving their care as well. And sometimes that can mean relocating the care to a health service setting or having two staff attend the appointment. Lots of different strategies like that. I've got a long list of controls that we can implement. So yeah,
it's done case by case. So you're presented with when you understand that there is an occupational violence risk there, then you can work with whoever's at risk to come up with an effective strategy to deal with that.
Yeah, exactly. And it's very different in an inpatient setting, a rehab setting, community health centre setting, and then a home setting, and we have services in the correctional facilities. So yeah, so it's quite broad, and I think that's the challenge that I like, and it's quite nice to be able to come up with some kind of plan. And obviously it's quite difficult to balance patient care and staff safety, so yeah, we have to get creative sometimes. Yeah.
Mm-hmm. So we talk a lot about psychosocial hazards on the podcast. So occupational violence is obviously, we've just talked about, it can be a safety issue for your staff. Can you explain how it's actually a psychosocial hazard, what that means?
Sure. So I think with occupational violence, and if it's okay, I'll just say OV because I'm going to be talking a lot next half an hour. But when we have an OV incident, staff, visitors, family, a lot of people are impacted, the organisation. And I kind of split it up into, I think, 4 categories. So we have that direct contact, where the person may be physically injured, and that impacts their life and their family, it can mean that they no longer can do the role that they trained for, which also obviously has quite an impact on the person. And then you can have that cumulative impact over time. So staff have been exposed to repeated low-level aggression, rude comments, racist comments, sexist comments. There's a whole range of types of verbal aggression that may occur, threats. And so that cumulative effect over time can impact people differently. So some people might have, a month or two of that and can't cope, and then others many years. So then we have witnessing OV. So a common scenario, well, not that common, thankfully, but a scenario of domestic or family violence spilling over into the health service. And staff will witness that impact on their patient, for example, might be experiencing domestic violence, and the perpetrator comes into the health setting. And that can be also distressing, noting that people in the health service have their own lived experience, potentially, of trauma, previous OV incidents. Domestic violence is quite, quite complex issue. And then the last one, which I think sometimes gets forgotten about, is vicarious trauma. So people like myself reading incidents on a daily basis that occur to our colleagues, and making sure you have strategies in place to manage that. And then there's support staff that may read type notes for a medical officer, for example, or read case notes when they're scanning it in. And there's also a lot of support staff that would witness this type of incident occurring: cleaning, food services, security, wards persons. Yeah, so I think that is probably a very long answer, but it shows how it can impact in many different ways that I think people might not be aware of.
Yeah, I think, you've just highlighted some of the examples of occupational violence in a healthcare setting and how they, affect workers directly or indirectly.
Yeah.
Mm. Yeah, and it's a very complex issue, I guess, and it does, there's lots of different effects and interactions with those individual factors as well, that, what people can cope with and their own histories and how those different things interact. So, it's definitely a complex issue to be dealing with. So Canberra Health Services actually published an OV strategy in 2019, and you were involved with that. Can you take us through some of the drivers behind why that decision was made to develop that strategy?
Sure. So in the Work Health and Safety team, we had started working on this issue by, like I mentioned earlier, tidying up the data. And what we did notice was that once it was classified correctly and in a standardised way, there was an increase in the issue across the organisation that was reported. It's very commonly underreported. And so we have that, and then we conducted a workshop to do a risk assessment, and that included a lot of stakeholders across the organisation. And that risk was identified as high, which is probably obvious to most people, but when you have it documented and what our current controls are in place, and I think it highlights that we need to do something about it. And then around the same time, we had a new CEO who was very passionate about this and provided funding for consultancy to develop a strategy, and did a call out for staff who were interested in being in the working group. So we included those stakeholders for the risk assessment, but we also had external stakeholders, so unions, WorkSafe, carer and consumer reps involved in that working group as well, because it's not just a staff issue. Yes, they were the drivers, and then having that executive sponsorship was very key to getting it going.
So you basically just outlined a few of the steps that were taken to create the strategy, overall. So it all started with, you had some internal data you mentioned. What was the nature of that data to begin with? Oh, so the data, you said the data was kind of coded, and
Yes.
then you conducted a risk assessment after that, the nature of that original data.
So the data indicated that over time we were having an increase in physical and verbal aggression towards staff, but physical is the one that's reported more commonly. As soon as somebody touches you, most people will report an incident, although they still don't sometimes, just because of busyness or, seeing it as part of the job. So I guess, which is one of the reasons why we have a strategy to raise awareness about this safety issue. And then the other thing that we noted was included in the data were things, were examples that were quite, that helped us define the issue, I guess, is what I'm trying to say. So we used that information to develop fact sheets for staff to give examples of what staff were experiencing. So being spat on, hit, kicked, punched, head butted, I saw, tripped over, pushed, things thrown at them. And so that, obviously we need to do something about that. That's not okay for staff to experience that, but also we have to include consumer and carer voices in that, because it's not just an us and them issue, if that makes sense.
Mm-hmm, mm-hmm. Yeah. Okay. So you had some, I suppose, incident data that raised some flags around. This is quite a widespread problem across the service. What was, if you could outline the steps after that were taken to actually get to the strategy, just to summarise for our listeners?
Yeah. I find it's really hard to summarise this work because it was it's quite involved. So we had that working group, and we had, I think there was like 80 to 100 people in a working group, which I think when people hear that, they're just like, oh my God, how did you manage that? How did that work? But we had really good leadership we still have good leadership, but we had good leadership that ran the meeting really well. And we engaged a consultant for about 3 to 4 months. So that was Aspects Consulting, who had done work previously with Vic Health. And they came in and were sort of part of the working group for the 3 months, spoke to the working group, got ideas, and did some consultation. So we did targeted consultation initially with the consultants, site visits, questionnaires that staff could send in, feedback to focus groups. So because we have a broad range of community-based staff, we did like a big working focus group, with all the community staff. So we'd have mental health, community nursing, maternal and child health nurses all in the same room talking about these issues, especially with the home visit that I mentioned before. So the consultant sort of compiled a strategy where we have 8 domains to address the issue. And when we got, then we presented to exec and got the okay to then start broad consultation, which I have, I got some stats for that, which now I can't find. So for the strategy document, we had 20 pages of feedback just for that strategy, which I think it's about 13-page document. For the policy, it was about 10 pages, and for the procedure, so there was 35 pages of feedback. So people are very engaged. They're happy to speak out. They have really good ideas, so that was great. I don't think the small working group that I got together that was looking through that feedback were very happy with me with that volume. But I think what it was good is that we got a strategy that was, I guess, was more geared towards a partnership with patients and carers. And we have a long way to go to get to that point, but it was heading in the right direction. And from a work health and safety perspective, usually you don't have that carer and consumer involvement in when you're doing risk assessments or developing procedures. So I found that really valuable, and I'm appreciative of these people sharing their lived experience with this issue. So that was tabled. It was actually tabled early 2020, in April, and the Minister for Health tabled that at the Legislative Assembly, the ACT. So it has a high profile and support from our government as well. So
sounds like a very big piece of work then, and I look
think
right
it
into it.
Tired just wrapping it.
Mm-hmm.
It was a really good year to get, and I think it was really important to get the foundations right and what our approach was. And we don't always get the time to do that. Sometimes you get told, just implement this. And the consultants reviewed literature around the world as well. So it was evidence-based approach, not just, I think this is going to work, go and implement, which is very old school, but sometimes that's what you need to do as well. But yeah, I like that we have a good foundation, and I think my Alexa thing just went off. It must have sounded like I said Alexa. We have a good foundation to go into the future and address this risk, and I think it will be combined with other psychosocial risks going forward as well.
Fantastic. Yeah, look, it's really good, I think, for our listeners in particular to hear examples of case studies done well. And I think that the consultation process that you've gone through there, having the right stakeholders involved, having the advocate at the executive level and having good data to inform your decision making are all really important aspects of a foundation of any kind of a strategy like this. So I think, this is a fantastic example to share with our listeners. Now, the strategy itself has 8 different domains. Can you take us through those?
Sure. So as I guess you can gather, this is a very complex issue in a healthcare setting. I think most settings it's complex. But in a healthcare setting, we have to balance patient care and staff safety and patient safety. So the 8 domains, I guess, is approaching it in a multifaceted way. And governance is the first one. If I forget one, Joelle, you have to let me know. Governance is the first one, and that is obviously getting your committee structure, what committee is going to have oversight of this strategy, executive accountability, and just getting all the policy and procedure through. So we had already kind of started that. So that was that governance domain was already commenced. And then the next one is prevention. So this domain is quite big and very broad and still we're most of the way through, but it covers things like having a risk assessment tool for areas to use, not just from a work health and safety environmental perspective, but a patient dynamic risk assessment. So, for example, we use behaviours of concern chart is what we call it, and some services use Brosset violence checklist as a base for that tool. And then we have different ones for pediatrics, and for geriatrics, so that it's patient cohort specific. Definitely a big factor is the design of safety and design. So ensuring that facilities that we do build in the future have good line of sight, no blind spots, safe furniture and fittings, so we don't have things that can be used as weapons. and things like that. So we have that embedded in our risk assessment tool, but also we are, as a work health and safety team, other team members are involved in those meetings, those working groups that are developing new services. We have a big one coming at the moment. Training is also a big one, so ensuring that our training meets the needs of staff. And I'll talk a bit more about that in detail later. But what we did get from the consultant was a framework for training that had some key principles, so ensuring that the staff providing the training have experience working with patients and addressing the issue, that we had dedicated staff, that the approach was customisable and team-based. So we got a lot of information from the consultant, to customise our training. Reporting, so I talked already a bit about that, how we fixed up our back end, standardising how we classify incidents, staff incidents, but we're providing more resources and education to staff on how to report. Well, what even is an OV incident? Response is another area. So this is an issue that will probably never be eliminated. So when we have an incident, we need to be able to have a good, well-coordinated response to the issue. So that covers that. And also we had a duress system implemented for staff that work in the home setting. And that's almost almost fully implemented. Okay, so support is another domain that's quite important. And we worked with the health and wellbeing team on the actions related to this. And now in the organisation, we're actually revisiting that in a broader setting. And we have currently in the process of working through initiatives to be implemented later in the year, because obviously with COVID and a healthcare setting, that support is well needed. So I think what was useful is that we used the support for other types of issues, so clinical incidents such as a death of a patient, for example. The same strategies can be used for a person that has experienced OV, but obviously it's just tailored slightly differently. The other investigation, so we just tightened up our investigation processes, and staff and consumer awareness is the last one. I feel like I've missed one, but maybe not. We talk about them a lot. And that one is sort of increasing awareness between staff and consumers, as well as detailing the mutual expectations or behaviour expectations of both. So we know that the behaviour of not just patients but staff can sometimes lead to an OV type incident or escalation of behaviour. I have a visitor.
Oh, we've got a cat on the screen.
It's distracting you.
It's a cat's job, isn't it? Just to come and interrupt. Yeah. So, yeah, look, I think that's a really comprehensive strategy that you've taken us through there, Peter, and I really like that you've covered sort of the full spectrum of different areas that you really need to think about in this type of an intervention or a strategy. And including looking at things like consumer awareness as well as staff. So you're not just focusing on your staff, but you're actually looking at, what is the role of the consumer in this situation as well. So I think that's really comprehensive.
So I was just thinking as you were talking too, because you kind of said, we started this in 2019, we kind of implemented some things from what was finalised early 2020, and now we're maybe 2.5 years in. What are the most successful initiatives that have come from the strategy since that time, the last 2 years or so?
I think it's a little bit early to say, because a lot of the things are only just implemented or final stages, like the training and the duress system, for example. But I think the visibility of the issue, the risk across the organisation has increased. We went from it not, people not really knowing what it, except for those high risk locations, people not really knowing that it was an issue for them as well, to it being talked about in every safety committee or team meeting. And then the increase in incident reporting. So we've noticed that there's a higher number of verbal incidents being reported. And that was not what we were seeing in 2018 or 19. You would have, and obviously if there's a physical incident, you'd expect that verbal would be higher. So I think that underreporting is being addressed. Still got a long way to go, but I think that is a really good reflection on the staff, taking it on, considering what they've been going through with COVID as well. And then we had implemented a poster campaign that was really well received by staff, could respect our staff, and that was a humanistic approach to OV instead of having our poster campaign with aggressive images of what the behaviours that we don't want to see. So I thought that was a really good way to increase visibility. And then I think the involvement in the engagement of staff. So I haven't really got specific initiatives that I think are successes, but what's come out of it, I think, is a success. So engagement of staff in risk assessments has been wonderful. I've been working with, I think personally I've done about 50, and that includes reviewing risk assessments for previous, for high risk, teams. And the tool was developed in 2018. I started with a colleague and tested it several times. So to see where it is now and the engagement from staff and the number of actions from the action plan when we developed an action plan that have been completed has just been really wonderful. We have, like, the emergency department, when we reviewed theirs and we were going through all the actions, it was yep, tick, or partially done. It's just really great to see. And that's one area that has been through a high volume of work in the last couple of years, as well as a increase in aggression. And I think, I was just going to say the security improvements across the organisation as well has one thing that's been really good. CCTV, duress, even knowledge of where the duress systems are for staff. We've got a duress map on our intranet, access control, improvement, increase in staffing, and also some units have dedicated security on site that are seen as part of the team.
So it sounds like there's been a big, shift and improvement in the culture around safety, that now, you're saying a lot of your staff and the workforce is really engaged in kind of, taking part in risk assessments and reporting, which we don't typically see. Safety, like you said earlier, no one really wants to do safety, or it's just seen as a check the box. But it sounds like there's been a big shift in the culture around safety there. So that sounds like a really big win.
And just even getting repeat customers or referrals from other managers or staff, we've seen an increase in that within our team as well regarding this issue. So, and then the team more broadly are able to address it. It's not just me. And there was another project officer for 2 years as well working on it. So I didn't, so I think that multidisciplinary approach has been really valuable. We had a nurse as a project officer, so that perspective was wonderful.
Amazing.
Well, Peta, this has been a really interesting discussion today. As I said, OV is a topic that we really haven't spoken about yet, and it's been fantastic to have this really sort of practical, almost a step-by-step guide for other organisations who are wanting to address this. So that's been fantastic. One of the questions that we ask all of our guests is if you were to look into the future, what would you ideally want to see there as far as workplace mental health goes?
For personally, I think being able to seek help for a mental health issue in the workplace and having no stigma attached. So I don't feel like we're at a place where if I fell over and broke my arm, I would be treated like I'd feel like I'd be treated the same way as if I went in and said I'm having panic attacks. So just like having that level playing field for those type of issues. And I think the speaker a couple of weeks ago on Are You OK Day, sharing their lived experience, I think that more of that needs to happen. But also that they shouldn't have to be seen as brave. It should just be normal that you do that. I think, but I think that for me would be the ideal, and that people will feel more comfortable asking for help in that kind of situation.
Yeah, so mental ill health just being seen as part of the human condition, the same way that physical ill health is sometimes, and that it's just part of life and something that we sometimes need help with.
Sorry, I'm rattling papers. I think
That's okay. So before we finish up for our episode today, do you have any advice or parting words for professionals, individuals wanting to work in this space in particular, whether that's just generally psychological health and safety or in a healthcare setting?
I think a lot of people on previous episodes have talked about professional development type strategies, so webinars, reading books, listening to podcasts. But I think what's really valuable is sort of looking at why you want to do it. Are you passionate about it? What's going to keep you motivated? And for me, I'm very passionate about it. So that helps me with my motivation. But also I think it's important to know that you have a good support network, because this is a tough area to work in. And you hear some really tough stories from your colleagues. And so I think having a support network and having some strategies in place when you're having a tough day, I think that for me, I walk to the auxiliary shop on the hospital campus and buy chocolate is probably not ideal, but that's one of my strategies. And then having some colleagues to debrief with, but being mindful that me debriefing about some incident can be traumatizing to them. So sort of doing it in a safe way. And I think that two key skills that you need, or I guess to think about, is that you have good communication skills so that you can consult, listen, and build really good relationships with staff. And that because they're the expert in that area of work, and as a work health and safety professional, maybe wellbeing practitioner, psychologist, we are in a role to support them to do a safe job or feel supported at work. So I think we need to really have good communication skills, but listening is definitely key in that role. Yeah, and so the last bit I wanted to mention was that this is a role that and an area that you can't address on your own as a work health and safety professional, or whichever angle that you're addressing it. You need to work with other professionals. So for me, I work with security and liaise with clinical staff, and sometimes I have called on expertise. So I have a friend who is a forensic psychiatrist that teaches at the uni. So I might call on her if I'm really stuck. And so I think it's a multidisciplinary approach. And there's also external stakeholders that can provide advice. So I think that's the advice that I would give.
Fantastic. Well, Peta, thank you so much for your time today and for sharing all of that wisdom and insight from what you've been working so hard on over the last few years. If we do have listeners who want to reach out and maybe follow up and get some advice from you, how can they get hold of you?
The best way is through LinkedIn. I'm happy for people to message me directly.
Yep, fantastic. Great. Thank you so much for that. And so that brings us to the end of the episode, listeners. So don't forget, we do post all of the videos on our YouTube channel, so you can check them out there. On our Flourish LinkedIn page, we will share some short clips from our episodes. So we've got some of that short form content as well. And you can always connect with Alicia and I over LinkedIn if you want to further the conversation. If you're interested in coming on, if you want to have something to share as a guest, you can hit us up there as well, or just to have a chat. We're always happy to hear what people have to say. So that's it for today, and we'll catch you next time.
You've been listening to the Psych Health and Safety Podcast. To stay up to date with the latest on psychological injury prevention, follow Flourish DX on LinkedIn and subscribe to the Psych Health and Safety Podcast at www.psychealthandsafety.com.